Bheerappa is going.
Yeah. I'm on the. Good morning.
Sorry. Dr. Bheerappa is going to speak on the acute pancreatitis initial management and assessment. So, Dr. Bheerappa doesn't require any introduction. He's a professor and head of the Department of Surgical Gastroenterology in Nizam's Institute of Medical Sciences, a senior surgeon and very active academically. So I request Dr. Bheerappa to start his presentation. Thank you, Dr. Bheerappa.
Good morning, sir. Respected Chairperson, Dr. Prasad sir, and Dr. Patra, thank you very much for giving me this opportunity. Am I audible?
Yes, sir, you are audible.
Yeah. Thank you very much for giving me this opportunity. My topic is acute pancreatitis and the initial management. So I believe the initial management would be in the first or second week of management in the treatment of acute pancreatitis. The later parts, like infective complications or complications, will be dealt by another speaker. However, I touch upon a little bit on a necrosis part and how to manage and how to diagnose that part also. So we know that there are two distinct phases of acute pancreatitis have been identified. The early week, which is 1 second. Are able to hear?
Yeah.
There are two distinct phases of acute pancreatitis have been identified. Early week, that's within 1 week. It's mostly characterized by a systemic inflammatory response syndrome, wherein body will respond for an insult occurred to the pancreas. And the later stage, it's later than 1 week or 2 weeks, where it's characterized by the local complications like peripancreatic fluid getting infected, or if there is a necrosis of the pancreas which is getting infected. So these are all the complications of pancreatitis. So I'll be mostly concentrating on early week response, early week treatment. So it's basically an acute inflammatory process of the pancreas with variable involvement of pancreas as well as the surrounding organs or surrounding tissues like retroperitoneum, omentum, and remote organ systems also. So the pathology varies from a simple edema of the pancreas to a necrosis of the pancreas and peripancreatic necrosis, or sometimes you can find an extensive necrosis of the retroperitoneum. It may extend up to the pelvis also. So the mortality, in fact, varies. So most of the times, the acute pancreatitis is mild, 70 to 80% it's mild, and it can resolve within a conservative management. Whereas in the 20 to 30%, 20% of the patients will have a severe pancreatitis, and in that they may develop a pancreatic necrosis. If the pancreatic necrosis is getting infected, the mortality, again, it will be around 30%. So we need to be very careful. So this can be avoided, infection of the necrotic part, then early death can be avoided by aggressive treatment in the initial stages itself. So what are the causes of acute pancreatitis? Mainly it's told gallstones and followed by alcohol. Sometimes ERCP induces a pancreatitis, but that percentage is less than 2%. It could be in a trauma, and since we see a lot of rotative accidents and we have an extensive experience of managing pancreatic trauma patients, and a ductal disruption and which causes a pancreatitis, or at a later period because of the trauma, there can be an stricture of the pancreatic duct and thereby producing repeated episodes of pancreatitis. As previous speaker was mentioning, the abnormality in the pancreatic ductal structures can produce pancreatitis, and various miscellaneous causes like hyperlipidemia, and of late we've been seeing an autoimmune pancreatitis. A good number of cases have been seen. If we do not find any etiology, probably we are putting them into an autoimmune pancreatitis. And there are few investigations to support autoimmune pancreatitis like immuno IgG, IgM estimations. And hyperparathyroidism, having an adenoma in the parathyroid gland, hypercalcemia, calcinosis, and that can also produce a pancreatitis, but these are all rare conditions. Hyperlipidemias, yes, high triglycerides sometimes do produce an acute pancreatitis, and sometimes in pregnancy. Some of the drugs do produce acute pancreatitis, basically cardiac drugs, but however, we don't see commonly. But what we see mainly are alcohol-induced pancreatitis and gallstone-induced pancreatitis. And of course, the trauma-related pancreatitis has been increased of late. So initially, there were mild pancreatitis and severe pancreatitis. It's been classified in Atlanta 1993. So mild acute pancreatitis, there is simple, there is no organ failure in mild pancreatitis. So that's most important. And they recover within a conservative management. Most of them will recover. And there are no any complications in mild pancreatitis. Whereas there is little change in the definition of the severe pancreatitis compared to Atlanta and the revised Atlanta classification. The revised one came in 2013. So severe acute pancreatitis, there are more, definitely organ failure is there in severe pancreatitis, such as a shock less than 90 millimeters of mercury blood pressure, whereas patient will have a high respiratory rate and with low saturation and hematocrit going up. All these are all seen in a severe pancreatitis. Whereas in 2013, these revised definitions, so mild pancreatitis, there is absolutely no organ failure and no complication. There's another entity in between severe and mild and severe is moderately severe acute pancreatitis. We have seen sometimes patient coming with some transient organ failure, which they get improved within a conservative management within 48 hours. So this has been taken another set of a group of patients here. And severe pancreatitis, of course, continuous persistent organ failure even after 48 hours. So they come under a severe acute pancreatitis. So this definition in the initial stages is very important because the mild pancreatitis, we'll treat them in a general ward with a supportive care. Whereas a severe pancreatitis with an organ failure, we need to take them into an intensive care unit and moderate and treat them properly so that the outcome is better. So pancreatic, sometimes we also see a pancreatic necrosis. Probably the patient comes a bit late, and if you do a CT scan, you see this kind of an extensive necrosis within a year within the pancreatic necrosis as well as in the peripancreatic fluid. And you see some of the raised markers like CRP and alpha-1 antitrypsin. All these inflammatory markers, they raise in this condition, and patient may also have, if there's an infection, you may also have a fever and raised counts, and it's typically an infected pancreatic necrosis. So this is a course of any acute pancreatitis. I'm sure Professor Shastri remembers me. He himself made this good slide, so I keep this slide wherever I go. So initial interstitial pancreatitis, edema pancreatitis, which the incidence is around 70 to 80%. The initial days you see within a week, and they resolve with a little supportive treatment without any complications. Whereas in 20% of patients, we see a necrotizing pancreatitis, and most of them in that group are sterile. They'll have a sterile necrosis, and some of them, say 10 to 20%, they may develop an infected necrosis. In those patients, the mortality is around 30%. So they may get infected, and we need to tackle. Now there's an entire the shift in the management of surgical management of a paradigm shift in surgical management of acute pancreatitis. initially we were definitely more aggressive in opening the abdomen and doing a necrosectomy, but of late it's all a minimal invasive therapy or treatment for a necrotizing pancreatitis. So some of the initial risk assessment is most important. As I said, to differentiate a mild and severe pancreatitis. So initial assessment is most important. Elderly people, so more than 55 years with comorbidities, or obese patients, BMI is more than 30, and if the patient has an hypoxia and with altered mental status, so we need to keep these patients in intensive care unit. And the systemic inflammatory respiratory syndrome. So if the patient has following two criteria, say more than 90 pulse and respiration rate is more than 20 per minute with PaCO2 of 32, and the patient has a temperature, raised counts, probably these are the patients we need to keep them in intensive care unit with a good central line and catheter placement. And the most important thing is resuscitation in the initial 24 to 48 hours is the most important. That is going to reduce the amount of necrosis, because the hypotension, if the patient has a hypotension due to third space loss in acute pancreatitis, there is a sequestration of the fluid into the tissues. So patient may have a hypotension. Hypotension can cause the acute tubular necrosis, so the drop in urine output, the hematocrit might rise, and there's a less perfusion to the pancreas, may be the reason for a pancreatic necrosis. So we need to look into all these things: urea, creatinine, hematocrit is a very important indicator, says that patient is not adequately resuscitated or patient is in dehydration. So these are all very important. Of course, a simple plain X-ray of the chest and abdomen may be useful because it shows a lot of pleural effusion. So we may adequately resuscitate them in this patient. So mortality, as I said, mild pancreatitis is less compared to severe pancreatitis, and the cause is initially, if you do not treat properly, and they'll have an organ failure and they may succumb. So in the initial management, the assessment is most important, and we need to manage according to the severity of the pancreatitis and try to detect the complication, and then find out what are the etiological factors for the acute pancreatitis. For example, if the patient has a gallstone, gallbladder stones, and gallstones have slipped into the bile duct, which has caused a gallstone pancreatitis, and the patient has in cholangitis in the initial stages. So there is a chance that if we intervene and they intervene with an antibiotics and an endoscopic sphincterectomy, the chances of outcomes are much better. So that's how we need to identify the etiology, assessment of the severity, and identifying the patient who is requiring to put in an intensive care unit, and aggressive initial fluid therapy is most important in acute pancreatitis. Of course, we all know they present with a severe abdominal pain and also sometimes vomiting. It's because of an ileus. Initially, they may have a fever. It's not because of infection. It's only because of the systemic inflammatory syndrome. They may also have a raised counts and fever. So that does not mean that these patients have an sepsis. So we should concentrate on a systemic inflammatory. It's in a response of the body. So we might see a raised inflammatory markers. So, and if the fever, patient develops fever in the third week or a fourth week, it means that whatever the necrosis or whatever the peripancreatic fluid is there, which got infected. So that's why this patient has a fever in the third week or fourth week. So, or sometimes fever also may be because of cholangitis due to a stone stuck in the bile duct, and then cholangitis. So they may have a fever. So we need to treat these patients. So patient might have an tachycardia if he has more than 120, 130 at the hypertension. it means that there is a good amount of sequestration of a fluid in the third space. So that's why he has an tachycardia and hypotension. And if you find him at height in X-ray, patient might have an atelectasis or fluid effusion. So may not be a very bad prognosis, but definitely he may have a respiratory compromisation. So patient might have an hypoxia because of low PO2 and hypotension. Sometimes we may get confused with an alcoholic withdrawal and hypoxia. You may have an renal failure because of low perfusion. These are the signs we may see in acute pancreatitis because of some subcutaneous hemorrhages. So we need to differentiate in an emergency medicine between a perforated viscera, intestinal obstruction, of course, mesenteric vascular event and acute cholecystitis, and sometimes pelvic inflammatory disease. So if postgraduate is in emergency medicine department, we should be very careful. Sometimes an examination, we might, if the patient, especially on influence of alcohol, it's very difficult to differentiate clinically that patient whether he has a perforation or an acute pancreatitis. So how to assess severity of the pancreatitis? So early prediction is most important, as I said, because you can initiate the treatment in the intensive care unit, aggressive intervention, thereby preventing complications and improve the outcome and to monitor the response therapy. That's the reason why you need to keep there. So disease severity, extent to the local tissue injury, which again due to most important determinant. So ideal predictor of severity, it should be reproducible. It should not be very cumbersome. Should be minimal, inexpensive, and we should be able to monitor. Simple. All these enzymes, we know that they are also raised in acute abdomen, but lipase levels more than 2 times is little higher specificity compared to other. So early good markers like phospholipase A2, and I know that these things are theoretical and may not be done in all the hospital, but at least C-reactive proteins, procalcitonin, which is more than 200 picograms, may definitely indicate predict the severity of the disease, and of course, inflammatory mediators. So we have various severity stratifications. I'm sure everybody knows Ranson's criteria, Glasgow scores criteria, Apache 2, multi-organ scores. So these are all the various scores. So we did little studies on Apache 2 score, which is I know that it's a very cumbersome, but very useful Apache score. So it is calculated every 24 hours and best predictor of severe acute pancreatitis. So this is a Ranson's criteria, which includes age, white cell count, and glucose, LDH. These are all the markers, and that is at the time of admission. And the initial 48 hours also, we follow with an hematocrit and urea creatinine, and of course, oxygen saturation. So Glasgow score is another score. Apache is it's a bit cumbersome, but very useful scoring system. If the points are more than 8, it indicates severity of the disease, and definitely we can say the mortality is around 18%. But the advantage is it definitely helps us to continually monitor the patient in intensive care unit. A simple X-ray for the sake of postgraduates I put. So these patients might, these patients will have a colon cutoff sign. It's mainly because of the peripancreatic edema and the edema in the colon. So it looks as if nothing is seen beyond. So in that, this is the colon cutoff sign. And you might see some fluid, and you might see a pleural effusion, and it might definitely helps in ruling out colonic, hollow viscous perforation. So these are all the findings you see in plain X-ray. Anterior displacement because of the space between stomach and transverse colon. You might see a sentinel loop that indicates only local ileus, does not differentiate with other acute abdominal problems, and colon cutoff sign. There will be renal halo sign, and you might see if there are any gallstones, calcified gallstones you might see, or you might see a pancreatic stones if it's in a chronic pancreatitis, acute and chronic pancreatitis. There is a chest X-ray wherein showing a pleural effusion, and ultrasound is definitely initial investigation, which might help us to to know the status of the pancreas. It might show an edematous pancreas if there is no gas, and a peripancreatic fluid also it will show, and presence of the gallbladder stones. And if the CBD is dilated or not, CBD stones ultrasound may not be a good investigation to know CBD stones, but at least if it is a dilated bile duct, so we think probably this patient might have a slipped gallbladder stone and causing a pancreatitis. So initial management includes supportive care with fluid resuscitation, the pain control, and the nutritional support. These are very important. Supportive care with the fluid resuscitation is very important. As I said, there is a sequelae of fluids seeping into the third space. So we need to give them aggressively fluid support. Best thing is isotonic normal saline or a ringer lactate. A saline 15 to 30 ml per kg body weight. Of course, it depends upon the central venous pressure, and one should be very careful in a patient who has a cardiac problem or a lung problem. So in that case, we should not overload the patients. So adequate fluid aggressive resuscitation is the most important. The ringer lactate, mine is gone. Prasad Garu.
Yeah, we are able to hear you.
But slide is on. Slide are able to see?
Yeah, we are in initial management, supportive care with fluid resuscitation.
Oh, yeah.
That's what we are seeing.
Yeah. Supportive care with fluid resuscitation, either with an isotonic saline or ringer lactate. Only thing is, when you are giving a ringer lactate, one should be very careful in a patient who has a hypercalcemia, or the patient, the cause of the pancreatitis, if it is a hyperparathyroidism and hypercalcemia, one should not give a ringer lactate because it will go into damage. So best thing is either normal saline or a ringer lactate. To start with, maybe you can start with an 15 to 30 ml per kg body weight, not exceeding 2 liters in that period in 24 hours. And again, assess again. The best thing is the renal, maintain the renal perfusion. See that urine output is 1 ml, 0.5 to 1 ml per kg body weight, and hematocrit. Hematocrit, if it's normal, then it means that adequate perfusion is maintained. Pain control, well, opioids can be given, but of late, many of us and literature also supports fentanyl as the best drug intravenous, either continuous infusion or intermittent. So fentanyl is going to relieve the pain very well. Of course, we avoid morphine because of sphincter spasm, and other opioids may be used. Nutritional support, if the patient does not have any ileus, maybe oral liquids or a soft diet can be started, and then after 24 hours. Only if the patient has a vomiting, the patient sometimes he may have vomiting because of peripancreatic fluid collection, compressing either the duodenum or in the stomach, or causing a local ileus. So in those cases, so we need to place a nasojejunal tube or nasogastric tube, and then feed them with an partially digested fluids available. So aggressive hydration, I said 200 to 250 ml sometimes per hour, and isotonic crystallite solution is better. Ringer lactate also preferred, and follow the hematocrit and urea creatinine. So indications to monitor in intensive care unit are: one is the pulse rate is very high, more than 150, trachy or brady, or if the systolic blood pressure is less than 80 millimeters of mercury, respiratory rate of more than 35 beats per minute, and sodium levels are less than 110. These are all the parameters where you see and then help you to keep him in an intensive care unit. So one important question always asked in any presentation is when to do CT scan, and also in the examination immediately the student says that yes, the moment patient comes, we'll do CT scan and confirm whether there is a pancreatitis or not. It's not true. So it should not be done immediately during the EMD, when the patient is in EMD. It should be done later date, say after 48 hours or 72 hours. It's better after 72 hours. So, but there are some indications like, diagnosis is uncertain. You're not sure whether it's in a pancreatitis or not. Yes, you may be allowed to do a CT scan. And sometimes assessment of the severe cases, if the patient comes with a shock, then maybe yes, you are allowed, depending upon again renal urea creatinine. The creatinine high, you may not use in a contrast, which may not be again useful to diagnose necrotizing pancreatitis. So in those cases, probably MR may be better. Or if you are treating a patient of acute pancreatitis is clinically deteriorating, there's another indication for an CT scan. And or if you want to do some interventional procedure, even in early days of the pancreatitis, because of compartmental syndrome, patient has a fluid which is causing compartmental syndrome, abdominal compartment syndrome. Maybe yes, you are going to your CT scan may be useful, and of course it helps in follow-up and monitoring the complications also. So a routine CT in all cases in emergency setup is in acute pancreatitis is not justified. So there are some limitations. Definitely a CT scan will not pick up a lower end CBD, a stone, small stone which is stuck at the lower end of the CBD. This CT is not a good thing. So it cannot detect infection of the lesion. Sometimes, if there is an air, probably we think some anaerobic organisms in the necrosis, and so it may helps. But if there's no air, and CT may not say that there is an infection. So it also helps in acute determination of peripancreatic necrosis. Sometimes it's not possible. So the CT grading in acute pancreatitis, it's called in a Balthazar grading. It's in a severity stratification done. And grade A is normal. Grade B is a focal or diffuse enlargement of the pancreas without any necrosis. Grade C, any of the above with peripancreatic inflammatory changes, but there's less than 30% of the necrosis. Grade D with 30 to 50% of the necrosis with single extra pancreatic fluid collection. And grade A is above all with more than 50% of the necrosis. So that's how acute pancreatitis grading is done. So there are all the various pictures showing inflammation and extent of the necrosis. You can see these are all the necrosis. This is the necrosis, non-viable. So if you give a contrast, so this necrotic part has not taken the contrast. It means that this is all the vessels are thrombosed and there's no contrast in this. And here you can see that there's an air pockets within the necrosis. And this is peripancreatic necrosis with fluid collection. You can see here extensive air in the pancreas. It's almost pancreatic and abscess. So that's how severity CT severe index is done. And if it is CT severity is 4 plus necrosis, then that's how it's calculated. So we can estimate based on the necrosis. If it's more than 30% necrosis, the morbidity is 94, mortality is also a bit how. So 0 to 3, it's mortality is 3%, and if it's more than 7, it's almost 17% mortality. So biliary pancreatitis, so there is a small stone slipped off gallbladder and stuck in the bile duct, which causes gallstone pancreatitis. It accounts almost 30%, and of late it's more because we are also seeing a lot of gallbladder stones in South India also. So they may have 60 to 70% mild to moderate pancreatitis, but they recover. So they may also have recurrent episodes because of small stones in the gallbladders keep slipping into the bile duct, and they may have repeated episodes and in 20 to 25% they may have a severe pancreatitis. There is a little difference between a biliary pancreatitis and alcoholic pancreatitis. Biliary pancreatitis, there is a bacteremia, patient will have cholangitis. The septic complications are more with the biliary pancreatitis than alcoholic pancreatitis. Alcoholic pancreatitis, so they'll have a pseudocyst, something like pancreatic ascites, and they may develop chronic pancreatitis, whereas infective complications are a bit more with a biliary pancreatitis. So how does these gallstones insert pancreatitis? So initially, our speaker was mentioning the long common channel, a long common channel wherein a CVD stone here. So there is a reflux of bile into the pancreatic duct and then causes activate the enzymes and causes pancreatitis. So similarly, if there is a sphincter of Oddi dysfunction, the diurnal contents might enter and the enzymes will get activated in a common channel, thereby producing a gallstone pancreatitis. Or sometimes edema of some stone is stuck here, and because the edema it slips back and the diurnal contents goes into the CBD or pancreatic duct and activating the enzymes. So we have important thing is if you do a liver enzyme, serum ALT is more in these patients, of course, in addition to the amylase and lipase. So that's important biochemical markers. And you may see sometimes a normal LFT also. And if you collect a diurnal bile, you'll see a small sediments of microliths. So microliths usually causes biliary stone pancreatitis. And so ultrasound will be useful to know, diagnose whether the gallbladder stones are there or not. And if the CBD is dilated, so might say that, yes, this patient had a gallstone pancreatitis. So this is a patient when CT was done. You can see here the small stones in the gallbladder with a pancreatitis and some necrosis here. So this is another CT which showing a gallbladder stones and with necrosis in the head of the pancreas. Here you can see that. So endo-ES is the best investigations which help us to identify the sensitivity, specificity is more compared to simple ultrasound and CT scan. So endoscopic ultrasonography, and if it's possible, intervention also can be done like endoscopic sphincterotomy, and that helps in preventing the gallbladder pancreatitis. MR cholangio also has less compared to endoscopic ultrasound. MRCP is not very great investigations in biliary pancreatitis. What is the role of an ERCP in biliary pancreatitis? There is only one indication for an ERCP in biliary pancreatitis is if the patient has a cholangitis, if patient has an sepsis. Otherwise, there is no indication for ERCP in patients with biliary pancreatitis. Even if the patient with cholangitis and pancreatitis, initial treatment is again antibiotics and treat the sepsis. If it's not improving even after 48 hours, I think urgent ERCP in the sense we don't inject a contrast, do an anatomy and balloon the stones. So this is a patient one we had gallstones and he had walled off necrosis. So we thought initially, we didn't know the history of pancreatitis in this patient. Initially, we thought it's a cystic neoplasm of the pancreas. It mimicked actually cystic neoplasm. Later, at the surgery, what we found is all necrosis, walled off necrosis, and this patient, we did an cholecystectomy with a necrosectomy. Mild pancreatitis, the basic general ward, basic monitoring, intravenous antibiotics. One important thing is in pancreatitis, antibiotics is not required at all. Even in severe pancreatitis, prophylactic antibiotic is not required. There's no literature support. However, in 20% of the patients, because they're put in intensive care unit, because they have a catheter, because they have a central venous catheter and urinary catheter and lot of IV lines. So hence, in 20% of the patients, not to rule out, not to prophylactic antibiotics, because we may expect some infections in intensive care unit. So that's the only where we may suggest some antibiotic. Otherwise, whether it's mild antibiotics are not indicated, whether it's like mild or in severe pancreatitis. Some feel that extent of the necrosis may be the indication for giving an antibiotic, but again, it's not. Extent of the necrosis is not an indication for a prophylactic antibiotics. However, there are some surgeons who give, if it is more than 50% necrosis, that they give antibiotic, but I don't think there's any literature support for that. So severe acute pancreatitis, central line catheter, nasovaginal tube, nasogastric tube. So these are all the things which so they may develop slowly the complications like pseudocyst, abscess. Sometimes they may have a pancreatic ascites and necrosis and other things. So I'm not going to deal further because our next speaker is going to speak on that. I'm going to say the necrosis part little bit. The necrosis might get infected through these routes, like an hematogenous route or sometimes transmural migration of antibacteria from the wall. So that's the reason why we need to, if patient has an vomiting, not able to tolerate, we may have to place a nasogastric or nasovaginal tube and feed them so that the mucosal integrity is maintained and bacterial translocation will not be there. So this is how we'll see. And whether to give a parenteral, yes, if it's not possible to give oral or enteral, then we may prefer a parenteral nutrition. Indication for a surgery in any is only infection and clinical sepsis. So clinical sepsis is the only indication for a necrosectomy, and postpone as much as possible beyond the 4th week only. And there's a lot of paradigm shift, and we used to do an laparotomy and necrosectomy, but we have enough literature supporting minor, minimally invasive procedures like percutaneous drainage of the fluid, or percutaneous drainage of necrosis, and endoscopic therapy, laparoscopic procedures. So all those, the problems which were associated with open surgeries, like a small bowel fistula, colonic fistula, trauma, bleeding, all these things can be avoided by minimal invasive surgery. We used to open the lesser sac, do a necrosectomy, we used to do a lavage. Now very little is done nowadays, so we don't do much. So initially we might do an percutaneous drainage of fluid, and this is a wherein you can see extensive fluid and with air in the pancreatic retroperitoneum and next to the spleen. And these are the cases where you can put, here you can see, you can see here air. So these are the best thing is to put an ultrasound guided percutaneous drain and drain as much as possible. And once Dr. Prasad, I'm able to hear.
Yes, sir. You are audible. We just come up to the time. I think we want to stick to the time. Okay, sure. Okay.
There's some problem here. That's why application is not responding. So anyhow, okay.
Okay.
And suddenly the system has become very slow. Yeah, this is one of our paper published wherein we could avoid 30% of cases with various percutaneous or endoscopic therapy so that the complications are minimal. So, Dr. Prasad, for giving me this opportunity.
Okay, thank you, sir. That's a very, I mean, acute pancreatitis is such a
close.
massive topic, and it's not fair to say, talk about it in 30 minutes, but again, for the constraint of times, we said 30 minutes anyway. So now there are a couple of questions. One you already answered. Is there any role of octreotide in acute pancreatitis? That's you already answered. There is no role. And another question is, how often can a post-renal transplant can develop acute pancreatitis? Are there any preventive measures?
Post-renal transplant, I have no experience, but yeah, they may develop pancreatitis because they are all on immunosuppression, and management is like similar. So there's no separate management for a patient who underwent transplant and developing acute pancreatitis. I have no answer for this.
And I think you covered all the areas. I mean, no role of antibiotics in the first stage unless there is proven infection, and no role of CT routinely, the only specific indications. I think the take-home message for PGs and UGs, I would say, is avoid hypotension and hypoxia in the initial phases.
Yes.
That goes a long way in treating these patients with acute pancreatitis.
Yes.
Okay. If there are any other questions, please unmute and ask. Otherwise, we'll move on to the next topic. Sir, can you stop the screen sharing?
Yeah, I'm stopping.
Sir, excuse me. On which day of the patient presenting to the casualty would you advise a CT scan, sir?
After 72 hours only.
Okay, thank you.
If there's a mild pancreatitis, and you may not need also if it's improving, but if there's a severe pancreatitis, definitely after 72 hours, not initially.
Okay, thank you.
Now we have our next speaker, Dr. Sachin Daga, who is a chief hepatobiliary pancreatic surgeon and liver transplant surgeon in Medicover hospitals, and also recently joined the ESI Corporation Medical College and Hospital. We have Sachin. I saw him in the.
Morning, sir.
Hi, Sachin. Yes, hello, welcome. Yes, I saw you. I saw your name earlier. So, if can you start screen sharing? I think Bheerappa sir's screen is still on. If you can come off, you will be able to, or just see if we can override his screen sharing. Dr. Sachin is going to talk on peripancreatic fluid collections and pancreatic time permitting pancreatic cysts.
Morning, sir. I thank sir for giving me opportunity to talk on the peripancreatic fluid collections.